I think we can open the discussion, and feel free to ask questions also to Professor Stanga. And I will hand over the word to Paul Runge with his experience on, together with our links and also the indirect ophthalmoscope from Keeler.
Hello, everybody. Thank you for coming. I basically agree with everything that Professor Stanga mentioned. There's a few subtle differences, and we all practice slightly differently, but I think the skill to be able to do a good indirect ophthalmoscopy with scleral depression is essential if you want to treat retinal diseases. You really can't get a good view of the peripheral retina, and much less treat the peripheral retina with laser. And even prior to this, when we were using cryopexy, just impossible to do it without scleral depression. It's an interesting skill set. I practiced in the U.S. in private practice in South Florida for over 25 years. I did a fellowship with Steve Charles, and that's really where I started to do indirect laser treatments. In fact, we published one of the first papers in 1991 in AJO about using diode laser for pre-threshold ROP. And we realized it was a very successful treatment, and it turned out it's really the best way to treat the peripheral retina. And then I went into private practice in Florida, but I returned in 2019 and spent 3 years with Dr. Charles teaching his fellows how to treat ROP. And then I completely retired in 2022. And since then, I've been in the Ukraine for the last 3+ years, Western Ukraine, in Albania and other places in the world, just basically teaching people how to do indirect ophthalmoscopy, how to do indirect laser, and how to look after ROP. It's interesting, in some parts of the world, in the US, it's certainly part of our training to use an indirect ophthalmoscope. But for example, in Ukraine, it's not. And a lot of people struggle with just even using the indirect to examinize. And I find other parts of the world, there is this kind of disparity. But anyway, it's one of the things that we did in the Ukraine during COVID. We sat down with some fourth-year medical students, and they had never used any kind of an ophthalmoscope, direct, indirect. And so we set up these small teaching sessions of 8 or 10 students. And we started out by dilating 1 or 2 of the students and then teaching them how to do direct ophthalmoscopy. And then we went to the indirect, and then we put on the Lion laser. We didn't laser the students, but we had some little photographs of retinas. And really very quickly, in 30 minutes or so, we got the students fairly competent and comfortable, doing this kind of work. Interestingly enough, when we went back and tried to teach some of the older, well-established ophthalmologists, it was more difficult for them to pick up some of these skills. So I guess youth has its advantage. But anyway, I do things basically exactly the way Professor Stanga does. A few little subtle things. I find that the Nikon 28 diopter lens has been my favorite lens for both examining and for treating. Unfortunately, the Nikon 28 isn't made anymore. The lens that was closest to it is the Volk clear field. They stopped producing those about 6 months ago. But the 2.2 lens that Professor Stanga mentioned is still available, and I think it is a good lens for doing this kind of work. The other thing is good pupil dilation, comfortable patient, and gentle scleral depression, and really having the light source as low as possible, because that bright light, once a year I have a dilated eye exam. I have diabetes, and so I see my ophthalmologist at the VA actually in the US, and the worst part of the exam, bar none, is the indirect. In fact, there's a colleague of mine who is a pediatric ophthalmologist in Anchorage, Alaska, and the nursery, the 2 nurseries in Anchorage where he works, the nurses are very concerned about traumatizing the babies. And so he did a paper where he took a dozen of us, myself included, and subjected us to an ROP exam, essentially. And so we put in the lid speculums, we did it with and without anesthesia, did dilation, scleral depression, and everything else, paled in comparison to just to the light from the indirect ophthalmoscope. And so using no more light than you need is very important, and maybe it would be a good lesson for all of us to be subjected to the exam so you know what your patients are putting up with. So anyway, if any questions about anything that I've said or Professor Stanga will be more than happy to go through any.
Thank you very much, Paul. Those are very, very good points. As Paul said, starting with low light is essential. And you can always press more, but start with low light, a comfortable patient, and very, very low pressure. What I'm going to say, I hope is not too controversial, but in my opinion, the problem here is that, well, problem is too strong a word. As you know, there is I hope I'm using the right words. I'm trying to be careful. There is some sort of association between Volk and Keeler. And the problem is that Volk has made such a great job at convincing everyone that a handheld slit lamp lens is good to see the peripheral retina, that now the problem is that people want to see the peripheral retina with a handheld lens at the slit lamp, and that's not really the way forward. And Volk still sells, in my opinion, the best lenses, but Keeler sells the best indirect ophthalmoscope. So there needs to be some compromise there between the two companies. Older ophthalmologists have fallen out of love of indirect ophthalmoscopy because there are more patients to be seen. It takes time to ask the patient to lie on the back in a supine position. The patient needs to be relaxed. All of this takes time. If you have to see 100 patients in a day, it's very difficult to do this. So you have to bear this in mind. But you also have to think, okay, this is what I can do, but this is what I should do. And this is the way I would like to be examined myself if I had an acute PVD. If you have an acute PVD, I'm sure you will want indirect ophthalmoscopy because a slit lamp examination is not enough. And we have to teach the younger to do it because otherwise, who's going to take care of us? Nobody will know how to do indirect ophthalmoscopy. Sometimes I think, if I have a PVD, who am I going to ask to do my indirect? I'm very fortunate because I've got Christos, our current fellow. He's very, very good. So he's learned how to do it. He's helped me to put these slides together. And I think I can ask him.
Yeah, there are a couple of points that Professor Stanga mentioned. You don't want to be really indenting, pushing into the globe. You just want to really gently kind of push the globe, and you'll see the indent fairly quickly. If you put too much pressure on the globe, you'll cause corneal edema, and you'll lose your view. So I think that's really important. Dr. Stanga, Professor Stanga also mentioned the Mainster 165. I agree with you. That's my lens of choice if I do a contact lens exam. I've looked at all of the contact lenses over the years, and there was a time when there was a whole evolution of things. Rodenstock had an interesting lens.
Yeah, yes.
But I always come back to the Mainster 165. Yeah, it's a great lens.
Paul you raised a very important point about corneal edema. I remember when I was a fellow and I was learning cryobuccal, and the consultant would say, you have 5 minutes to find a tear. If you don't find it in 5 minutes, I take over, because after that, the patient develops corneal edema. 5 minutes is a long time for the patient. It's like an hour in real life. So it's 1 minute per eye. In 1 minute, you should be able to see the 12 clock hours. Do we have any, we need to close. Do we have any questions? If you have, please ask now. We are going to stay around, Paul and myself, for some minutes.
There is one other important point. The view in the Norlase indirect laser is much, much better than any other indirect laser. The reason for that is there's filters in the scope to protect the operator from the laser. And so what Norlase has done, they've actually narrowed that filter to the degree to where it protects you, but it doesn't decrease your view. And the first time I used the Norlase Lion was in 2019, and it was the first laser they had delivered worldwide. It was with Dr. Charles in Memphis, Tennessee. What we were using up until that point, I was using primarily the iris laser, and then with Dr. Charles, he had an Alcon 532. And when I went to put on the Norlase laser, the view was just so much brighter and better. And in fact, I thought in a perfect world, in my exam lane, I wouldn't have indirect ophthalmoscopes. I'd have Norlase lasers, because I would often examine a patient in my office, and I would find a tear, and then I go to the laser room and I put on the laser, which was an iris in those days, and I couldn't find the damn tear. You know, and then I would have to go back and put the indirect on and say, oh yes, it's there, and then go back to the laser. But with the Norlase, oh, sorry. So with the Norlase laser, you don't have to do that because the view is that good. Anyway, sorry.
We have time for 2 questions from the floor.
What is the role of the Minister 165 in examination? This is number one. And what type of laser? Yellow, green, you use?
Sorry, I couldn't hear.
What is the
The
type?
one I use, a green laser.
The green laser. What about the role of 165 Minister lens for the examination, not for the laser?
What about what? I couldn't hear it. Sorry,
Lens,
there's a lot of
lens.
echo at this
Yeah,
at this.
lens 165, the one which you're using for
Yes, the
in
mainstream.
examination,
Yes.
not in the laser. Did you use it for the examination?
No, no. No. I don't use the 165 for examination. I examine the peripheral with the indirect ophthalmoscope.
But to answer your question, yes, you can laser with the Mainster 165. Yeah.
Are you any worried of the patients moving their head while you're performing laser? Or the eye?
No, because you when you hold the head, well, first the patient is once if you explain to the patient is relaxed, and you are holding the eye in a way when you are doing the scleral depression, and with I'm right-handed, so with my left hand I'm doing the scleral depression. With my right hand I'm holding the lens, and that also stabilizes the head. Unfortunately, we have to come to an end because otherwise Sandy Brooker will kick us out.
Thank you very much, everyone, to come. I invite you to come to the Norlase booth 43 to do some hands-on training with the indirect and also with the laser, if you like. We have a present for you also, if you like to come.